Good morning, everyone. I'm Larry Boris, Executive Director of the National Association of Worksite Health Centers. I want to thank you for participating in today's program. This is what we call our First Monday Roundtable, and it's a little bit different than most of the programs that we have in that there's more interaction on behalf of the participants here. But so first, a little introduction. For those who are not familiar with us, the National Association of Workplace Healthcare, formerly the National Association of Worksite Health Centers, is a leading membership organization for both employers and unions who have on-site, near-site, mobile, and virtual health centers, as well as those health providers, vendors, clinics, providers, etc., who help manage and support these activities. We assist both the purchaser and the supplier side in developing and expanding their capabilities to offer primary care, wellness, occupational health, and other services through a worksite center. We offer educational programs, networking, benchmarking, and a clearinghouse of information. I hope you'll join us for our upcoming programs. Next month, we have our May 13th, or later this month, on Rethinking Employer Healthcare, what organizations are doing. Our program in St. Louis, I forgot to take that one off. Hope you will all be able to attend that. First Monday Roundtable in June has not been identified as a topic yet, but it'll be similar format to this one. June 11th, we have a topic on occupational health services at the center. And June 25th, 26th, we join the World Conference Forum in Chicago for the 2026 On-Site Employer Health and Wellness Center Conference. So the format is I'm going to go through everybody who's on the call today, just ask you for your name, your organization and title, general responsibilities. Just take a moment. And then so we know who's on the call. We'll then have an overview of the topic by our content experts. And then following that, we'll ask each person to share their own experiences, comments, questions, any information or recommendations relating to addressing cancer at the worksite. We are recording this, so you don't have to take copious notes. A link will be sent out to all participants, as well as the slides, and it will be sent out in our newsletter, etc. So when I call your name, if you would just identify yourself first. So let's start out with our Bart Trench. Bart, would you just introduce yourself briefly? Bart? Okay. Betsy Noda would you introduce yourself, please?
Hi, good afternoon. Betsy Noda Kirby. I'm the Senior Vice President of National Health Management Consulting at Marsh McLennan. And in my role, I'm the National Practice Leader for Population Health Management. And I also support our National Practice Leader, Dave Beach, with worksite clinics and consultants. And that's me.
Great. Thank you, Betsy. Tim Newman. Tim, would you introduce yourself, please?
I'm an occupational physician and work with a large power company and also a member of the NAWOC Medical Advisory Committee.
Thank you. Again, Bart Trench, introduce yourself. Okay. Deanna Hahn. Deanna, would you introduce yourself, please?
Hi, Deanna Hahn from SSM Health. I'm a director for our occupational medicine and direct-to-employer clinics in Wisconsin.
Thank you. Ed Schwartz. Ed, would you introduce yourself, please?
Hi, Ed Schwartz, National Medical Director of Premise Health.
Thank you. Frank Cohn. Frank, introduce yourself, please.
Thank you for the opportunity, Larry, to learn. Frank Cohn, Birmingham, Alabama, independent healthcare advisor, working with large self-funded employers. Thank you.
Great, thank you. Jim Meacham. Jim, introduce yourself, please.
Hi, everybody. Jim Meacham. I'm Vice President of our direct-to-employer partnerships for SSM Health at work here in Wisconsin. Also a new member of the NAWOC board as well.
Thank you very much. Christian Johnson. Christian, if you'd introduce yourself, please. Christian? All right. Laura Mendick. Laura, would you introduce yourself, please?
Hi, Dr. Laura Mendick. I'm with SSM Health as well, and I am our Wisconsin statewide medical director for our direct-to-employer offerings and occupational health.
Thank you. Lauren Emery. Lauren, introduce yourself if you would.
Hi, everyone. My name is Lauren Emery. I do health promotion and outreach for Larimer County.
Thank you. Maria Berengi, Maria, introduce yourself, please.
Oh, yes. Hi, good morning, good afternoon. My name is Manny Berengi. I'm an occupational and environmental medicine physician, associate clinical professor of medicine and public health at the University of California, Irvine.
Great, thank you very much. McKenna D'Souza, please, McKenna.
Everyone, McKenna D'Souza, wellness analyst with Quick Trip. My role supports the strategy of our 3 on-site health clinics operated by Premise Health.
Great, thank you very much. Nick Thanis, Nick, introduce yourself, please.
Hi, my name is Nick Thanos, and I'm the director of our SSM Health at Work line, kind of in central Wisconsin. Work with local area employers, occupational medicine, direct-to-employer clinics, those sort of things. So good to meet everyone.
Great, thanks very much. All right, our speakers today are Robert Bard, President, National Cancer Treatment Alliance, a clinical integrated network, and J. Michael Webb, a physician leader, quality control at the Check My Spot. So, Robert, why don't you introduce yourself, please, and as we'll get started.
Yeah, everybody. So thanks for joining this morning or afternoon, depending on where you're at. I'm Robert Baird, the president of the National Cancer Treatment Alliance. We are a clinically integrated network for independent oncology practices. You can go to the next slide. Yeah, so one of the reasons that we came together and developed the National Cancer Treatment Alliance was really to focus on the self-insured employer market. And the reason this came about is, through our parent organization, we do a lot of educational programs. And we started to notice over the years that there were benefits advisors, independent, self-insured employers attending our meetings. So we decided to form this organization to focus really on the self-insured employer market. And the reason that is because we know there's a lot of employer challenges with cancer care services. It's really got their attention in both numbers and costs. Anywhere from a half to a third of your employees either will develop cancer themselves or be a caregiver for someone who does have cancer. And we all know the cost impact that can be. Most employers, on average, can spend anywhere from 10 to 20% of their healthcare spend on cancer care services. And that includes a lot of things such as productivity loss. And that's not including things as productivity loss, workforce disruption, and caregiver burden. The other reason that a lot of those indirect costs happen about productivity, workforce disruption, or it's really the reasons I talked about before. Employees that are developing cancer, it's becoming much more prevalent the older as the population gets, and really also becoming a caregiver for someone else. Because if you're a caregiver for someone and they're at home, a lot of times that's going to take up your time. It adds additional stress, which can lead again to workforce disruption and productivity loss. So there's been a lot of surveys. This survey is from 2023, and it's been pretty consistent. The top 3 conditions are cancer, musculoskeletal injuries, and cardiovascular. And I think, cancers are beginning to really show up in number 1 in a lot of these categories with studies that have come out. And you go to the next slide. Yeah, so really what we're focused on is really raising awareness of the value of community oncology and really the independent community oncology practices that we support as part of our network. There's been many studies. Our parent organization has done many studies on really the site of service differentials, because the evidence-based cancer care that we provide at our centers can be anywhere from 30 to 50% lower cost. A lot of these costs really are related to some drug cost differences in terms of the way that the reimbursement goes between hospital-based care and independent community oncology practices. Also with 340B drug pricing, I know there's a lot of business groups and a lot of organizations because the hospital systems can purchase drugs at a much lower cost due to the 340B pricing structure, and those costs are not shared. Those cost savings are not shared with self-insured employers in the commercial market. They can get those drugs at anywhere from 30 to 50% discounts and still mark those drugs up, to 4 to 5 times. And so really making a huge profit margin on that. And that's just not available in the community oncology setting. We know that community oncology practices are care close to home and work, and then providing much, needed navigation services for employees and their for their employees and the people that are undergoing treatment, and really high quality personalized care, providing really high cutting edge technology and therapy such as immunotherapy, bispecifics, and CAR T therapy, which are really can be managed in the independent community oncology setting. So you can go to the next slide. So one of the things a few of our practices has done is they developed with some of the on-site clinics is they've developed really a joint navigation model. So really where some of the patients or the employees that do enter that do have cancer care, really the initial navigator at the on-site clinic can help them enter the system. And that means usually coordinating an appointment with an oncology navigator, one of the local independent community oncology practices, and really help guide them through the treatment. They'll do that on site. So the two can work together, really helping to reduce no-shows at the practice, avoiding treatment delays, getting that employee under treatment faster, and really patient confusion. There's a lot being thrown at somebody who develops cancer. It's a life-changing event. There's not only costs about, your family and how you're going to feel and, be successful during the treatment, but also really the financial costs. That's one of the big things that I hear about from our network practices are really the financial impact in terms of copay, co-insurance, and really just concerned about missing work. You go to the next slide. So a couple of things these patients can receive, in the coordination with an on-site health clinic between the local oncology provider and the on-site health clinic is really they can support a lot of the symptoms that can happen through the treatment of oncology and just the stress of having, a cancer care diagnosis, including managing fatigue, nutrition, and helping with coordinating mental health or providing on-site, counseling services, really helping that patient understand and monitoring some of the visits between oncology. Patients with cancer and undergoing treatment are monitored very close by their practice, and they're a phone call away, but it just really helps having somebody that they can visit on site to really talk about that. Some of the clinics can handle minor acute issues such as dehydration and certain infections. And of course, coordinating disability and leave paperwork that's very, very important to make sure that employee has the benefits that they're eligible for. This can help improve the patient experience and really keep those oncology clinics focused on high quality acuity care. And you go to the next slide. Many of the oncology clinics provide at the worksite center through these joint initiatives can also provide a lot of workplace screening campaigns. These include lung screening programs. There's a practice we have in Arkansas that coordinates with a mobile lung cancer screening program and goes to various work sites. These could be smoking cessation programs, healthy diet programs, things of that nature. Also, vaccinations drives. The HPV vaccination is one that has been studied and known to prevent some cancer types. And of course, talking about survivorship and return to work planning with many of the oncology medications that are out there and some that are in the oncology pipeline. Many of these conditions are, these patients are doing very, very well. Survivability is doing very well. So it becomes more of a chronic disease. And you go to the next slide. So a little bit more about our integrated network before I turn it over to Dr. Webb. Is really our national, the NCTA Clinical Integrated Network is a national network of community oncology practices providing affordable, accessible, and high quality cancer care. And as I mentioned, we do have the ability to contract directly with employers, insurers, and other stakeholders. But one of the things we're really trying to do at this level is really just to provide awareness and education and information on the importance and the value of independent community oncology. We just want to make sure that your employees are receiving, high quality care, excellent patient experience, outcomes and access, and the employer can have the ability to reduce costs. As we know, with all the other costs we've got going on, healthcare is still, the number one expense, and to really be able to provide resources such as education, navigation services, and survivorship programs. You can go to the next slide. So again, these benefits that employers can see by using, community oncology providers is really a flexible network of high quality, affordable local cancer care providers with tailored solutions. And our group really does a lot in the self-insured employer market and really, attends a lot of national meetings, provides a lot of resources, a lot of networking, really leveraging our expertise of the national network, really creating solutions on how employers and purchasers and providers can work together to transform cancer care services for employers. You go to the final slide. And this is just a little bit more. We do have a large network. They are independent oncology practices. We have 44 practices in our network, almost 1,000 providers with 260 locations across 27 states. And my contact information will be shared. So if you want to learn more about maybe a potential independent practice in your area, just reach out to me and we can help connect you with them. And thank you.
Great. Go ahead, Michael. Thank you. Turn it over to you.
Great. Thank you, Robert. That was an excellent presentation. I look forward to connecting and hearing more about what you're doing, the great work. I'm Mike Webb. I'm a Mohs surgeon in North Alabama, Southern Middle Tennessee, Northeast Mississippi, and I've been on the front lines of taking care of avoidable advanced skin cancers during that time. And I've had the unique perspective of being both the big end of the funnel and the narrow end of the funnel. So I know what the wins are in advanced cancer, and I know what the losses are in advanced cancer. And it really boils down to a couple of key features I hope to share with you today. My mission has become to help get people to definitive treatment sooner, which is a parameter or a clinical measure that most definitely correlates and strongly correlates with improved survival and reduced cost. And what excites me is how closely that mission aligns with NAWIC's work to keep employees healthy, engaged, and productive. Next slide, please. So before we get started on any discussion about skin cancer, it's important to notice that it's not a single problem, but it's rather two categories. You have non-melanoma skin cancer, which is very prevalent, produces a strong annual spend year over year. It's very common. And then in contrast, you have melanoma, which is the other major type, which, if not caught early, can be financially and from an outcome standpoint, catastrophic. Next slide, please. Keeping those two distinctions is very important because Rob laid out why getting folks into care and getting into a community system matters. What I want to do now is to talk about why does it keep failing in the workplace and what are some strategies that we can approach to help fix that. Rob mentioned that it's the #1 driver of employer health spend, and it's not because care teams are not trying. The real cost drivers are upstream in late diagnoses, delayed specialist access, and long tails of disability and work disruption. And while employers may not control therapy pricing, they can influence whether cancer is detected early when outcomes are best and costs are lowest. And I'll say this from 30 years as a cancer surgeon. Every advanced case I treat represents a system failure upstream. It's not a bad doctor. It's not a bad patient. It's just the process is bad and it can easily be improved. Next slide, please. And I want to draw your attention to this slide because I think it's one of the most important slides in the deck that I want to share with you. It highlights the only lever that employers truly have, which is called stage shift. And it isn't just about early detection because it only works when early detection is paired with early definitive treatment. The clock is at running anytime someone has a tumor. And in surgery, we don't order a test unless we already know what we're going to do with the result. And workplace screening should work the same way because finding cancer only matters if there's a clear and timely path to act. And when that doesn't happen, employers absorb catastrophic claims, not just from the treatment, but everything that's required to stage and manage the advanced disease. It's imaging, pathology, genetic testing, specialty pharmacy therapies, hospitalizations driven by disease spread, and complications or treatment toxicities. And unfortunately, despite all that added spend, late stage care hasn't meaningfully improved survival or productivity, with over 30% of stage 3 and 4 patients ending up on long-term disability or dying from disease. And it doesn't bend costs or outcomes. Real ROI comes from that stage shift phenomenon that this slide illustrates. If you look between stage 2 and 3 and 3 and 4, if you can catch these cancers, and I'm using melanoma as an example for all cancers because it is Skin Cancer Awareness Month, and it does happen to be the area that I deal with most specifically and often. You'll see that parabolic rise, and underneath, and you'll have to come back and look at these slides later, the fine print shows you why it's a parabolic cause. And it's important that integrating early detection with early treatment into your health strategy is key in getting this stage shift to occur. We have to get people aware and in for screening earlier to keep these costs at a minimum and outcomes the best. And for employers, cancer screening return on investment, and many of you know this already being in the business, it's not about detecting volume. It's just about catching that single case to avoid that catastrophic outcome. Next slide, please. So this is a brief slide, and I really just want you to focus on the size and stage of both non-melanoma and melanoma skin cancers. You can imagine other cancers fall into this same category, but as cancer progresses, so does time away from work, and it can take something from a simple 2 or 3 day or 7 day visit and low claim cost for a stage 1 or 0 cancer of any type. And it can rapidly escalate into a 3 or 4 week high dollar catastrophic claim that has a significant risk of disability. This slide illustrates that for melanoma. Next slide, please. And what I do want to share with you also is that in melanoma particular, but other cancers also, there has been tremendous advance in specialty pharmacy, and it does move the needle on improvement in outcomes, particularly for younger patients and helping them live longer. But it adds the total spend at a price. And even so, particularly with melanoma as an example, PD-1 therapies, which are a great new targeted form of therapy, still fail about half the time and disease progresses. And PD-1 indications are expanding out into earlier stages. So you're starting to see more standard of care call for PD-1 earlier in disease. And if you have worked on the total spend at all, you'll understand that, for example, Keytruda is the classic PD-1. It's roughly wholesaled out, and Rob can comment on this later, but 12,000 a dose, and you're looking at cases that normally are Q3 weeks, and they'll go for 6 to 8 months. So your spend on specialty pharmacy is large and getting bigger if it is needed on these cases. Next slide, please. The last thing I want to say about the specialty pharmacy is with half of those failing, there's a new form of therapy, and Robert mentioned it earlier regarding CAR T therapy. TIL is the one that we use in melanoma. That's where you harvest lymphocytes, you amplify them outside the patient, you lymphodeplete a patient, which all of this is required inpatient, multiple ancillary costs associated. Then you reintroduce these lymphocytes as a single treatment with a price tag up over $650,000 for that single treatment. So my point on all this is it's the costs and the value, the cost of cancer in advanced stages is only exploding, and the value of having an effective workplace screening strategy becomes even more important and relevant. So if stage shift is the lever that changes outcomes and costs, here's what it actually changes from day to day. For employees, their survival improves dramatically. They require less invasive surgery, which means better recovery times, better quality of life, and cosmetic outcomes. And your employees have lower psychological burden due to the uncertainty they experience with a diagnosis of cancer. And it keeps them healthy and productive in the workplace. And for employers, it means you get fewer catastrophic claims and your spend is more predictable. And your employees have a stronger trust in the on-site clinics. When you screen them and you find a cancer early, that's a huge win for all parties. And it keeps the workplace moving forward and being productive. It's pretty simple. Early detection means early treatment that saves lives and dollars. Next slide, please. Stage shift is the win, but workflow friction is what keeps us from achieving it. So on-site clinics, as we all know, we have them, they're incredible assets, but they're not the specialty centers that often are required for dealing with advanced oncology. They do address a wide spectrum of disease, but they're time constrained and they're designed for throughput, not necessarily a diagnostically complex issue. Screening tools are a great implementation, but they fail if they demand a heavy operational burden, such as a calibration, maintenance, or updates, if you've got to change your clinic workflows, or if you have to add extra appointments. And I know many of you who are listening know this already by experience. I appreciate that also being a clinician and how valuable workflow is. And what I have found is the hard truth about this. If a solution for cancer screening adds more than 2 to 3 minutes, its usage is going to collapse. And I'll say this as a surgeon and a founder of a solution very plainly. Adoption beats accuracy if the accuracy never gets used. And another way I say it in dermatology is sunscreen never works if it stays in the bottle. So we got, the key is getting utilization for these measures, as you all know. Next slide, please. So if we know it matters in cancer screening, the next step is knowing how to evaluate what you're already using. And you got to have the sensitivity for this condition at the right stage. You catching a stage 3 or 4 tumor really doesn't do much to move the needle. So if you have solutions in place, they really need to be sensitive for early stage cancer detection. And there's many solutions out there, and I'm going to sort of give you a checklist to guide in a moment about how to do that. And the second thing that's very important in clinic workplace solutions is that your tools have to have a specificity that avoids chaos, because false positives don't just cost money, they create fear and they overload your clinics and they'll erode trust in the employees that you might take care of or help provide health care for. And then when you're looking at your current solutions, figure out how much friction it has to decide if it's a good one. Who has to touch it and how long does it take? And is it the kind of solution that at 4:45 on a Friday afternoon, you're going to activate the screening tool? Because if it's not, it needs to go or be replaced with something that's better. And then last, this is very important to me, is what's the follow through on that screening tool? What happens if it's positive? And who owns ensuring that that care loop is closed? Because again, if you detect something early, that's great, but it has to be treated early to see the benefits of those outcomes. So screening without navigation is just data production. And your employees don't want data. They need a clear action plan or they're not going to participate. Next slide, please. Once you know what you've got, you really then need to know what's the next risk that's there, and it's being distracted by what's new. And there are a lot of solutions that get pushed out to you, particularly for skin cancer screening in your clinic. And here's a little formula or a quick 5-question how to pressure test what's being put out in front of you, because you'll hear every vendor promise you the future, and you need to know how to separate signal from noise. So in these questions, you need to ask, where exactly is the delay reduced? Is it discovery stage, triage, access, time to definitive treatment? Each of those matter. And then who's doing the work? Is it going to be the employee has to do it themselves at home, or is it the nurse who's operating the clinic, or even the primary physician or provider, or is it even require specialist care? And what does it cost? And is it applicable and feasible for you to integrate that into your workflows? And this is very important to me because I treat advanced cancers. What happens after a positive? Is there a pathway, or does it just simply get sent off into a black hole? Care loops have to be closed if you're going to make a difference, and they have to be closed in the shortest amount of time possible for the greatest impact. And then also, when you're looking at something new, if it fails, how does it fail safely? Is there a QA system in place? Is it qualified human oversight or override that can take some of these false negatives or false positives and apply reason and sensibility before activating the patient's awareness so that you can make certain that things are kept in a productive manner that moves forward? And I see a lot of errors that happen high AI accuracy that doesn't have workflow integration. is a real problem because some of these solutions are full of what's called spectrum or promotional bias and not reality. And that simply is that they're training their data sets for outcomes that they desire or want. And you really need to have someone who's qualified to evaluate that, and you need to be dealing with vendors who are transparent with their data sets. So AI solutions don't often offer that transparency that you really need. And then solutions that require everything to be in place and perfect, steer clear of those. They simply fail because of the reality of working in a health clinic. And then you don't want any system that shifts risk quietly back to the clinic, meaning who's going to take care of these positive tests and follow-ups and liabilities, and how do you have systems in place? And I'll say from my experience, even great solutions, they can fail in clinics, but if you're choosing a vendor, choose one that can make them work, because the good ones really will make something new and innovative and tailor it to what it is that you need in your clinic for your employees. Next topic, please. So here's where the work begins, and I just included this slide because it's a nice differentiator for different screening solutions that seem to be really good. What I want to point out is that every technology solves a problem, but none are solving the whole chain of getting folks who've been screened to definitive treatment sooner and then closing the care loop. Telemedicine solutions are outstanding for triage and faster access, but they're limited in their full care because many times follow-up requires a system to analyze medicines and prescribe medicines, and even some state regulations require physical visits even before telemedicine can be activated. A popular one is mobile vans and screening vans, and they do well for targeted populations. So if you'll do a population health analysis to see what the risk stratification is for the condition you're screening, those are the ones to send the vans into. You do get high engagement, but they are costly, and they do require logistics investment and time, someone to help coordinate the van driving, placement, stocking, funding. Serum and patch and serum tumor markers, they are good. They'll spare some biopsies, but if you're going to get a definitive diagnosis, it's still going to require a biopsy and pathology in an in-office setting. So your ROI is somewhat mitigated on that. Handheld devices, they add hidden work. They require maintenance, training, calibration, and updates. And then you've got to have some technical reproduction to effectively use these. Mobile apps could do better with access, and there's no operational upkeep because you've got Apple and Samsung and Google. They're all taking care of the device purchase costs. But again, they're in that mobile category that you have to have a follow-up in-clinic care loop for it to be effective. I'm a big fan, obviously, of the mobile apps because it actually empowers patients at point of discovery or provides specialty care in a primary or occupational clinic. You can get an immediate specialty consult to help share liability for an issue that you might not feel comfortable with managing that risk. And then I won't bash AI too hard again. You've heard me say it already, but it should always be used to support human decision making, not replace it. And there always has to be human governance involved for multiple reasons. One, because you're taking care of folks, and you have to have folks who are managing those hallucinations or other outcomes that simply don't make sense as they're being applied. And so, and in addition, the medical legal liability for AI is not clearly outlined. And the last thing I'll say is that, really, if you're looking for a screening solution, the ones that are transformative, they can do more than one job, because when detection, access, and action align, the utilization and value accelerate, and you're going to make a huge difference both in your patients and employees' lives, but also in the cost and the bottom line for the company to help keep your clinics productive and moving forward. And that's next slide, please. This is a checklist. You can download this. This helps you analyze what you might want to do. We've talked a little bit about this in finding effective tools for your clinic. This just reviews what I had done. It might be a slide to screenshot or copy and use later. Next slide, please. So I'm very excited to have shared this, and a big fan of the work that Larry's doing with the NAWIC. And anytime clinicians, employers, and innovators align, outcomes improve, costs are reduced, and we all win when we work together. So I'm looking forward to answering some questions. Thank you.
Great, thank you very much. Michael, before we jump into the roundtable, could you talk a little bit about the blood tests that are out there now for screening cancer?
Yeah, so there are several serum markers, and they're good for screening tests in high populations, high risk populations. The sensitivities are actually quite good, and the specificities, and those data sets are trained. So if you're looking for panel tests, I think that's a very good place to start, depending on which type panels that you're interested in. Then you'll need to, again, check their sensitivity, specificity for each disease type that you're trying to screen for. But they're simple and easy, and folks do like the idea that they can have something done quick in a quick clinic visit and then have a follow-up test result.
Yeah, I think one of the areas of most interest to many employers is that the blood tests, for example, like for colorectal cancer, can be done as part of biometric screening. It doesn't require the patient to do anything. And there's been a challenge with the tests that people have to go home and take a sample themselves and send it in. Many employers find people don't turn them in. What's your experience been on that?
Well, my clinical experience is in melanoma, and so we really don't have a great melanoma serology marker that we implement diagnostically in this specialty clinic. But the other tests, and I know my colleagues, when I speak with them, they're getting good feedback in returns and patient utilization and interest in many of these multiple antigen assays for these tumor markers. So you're right, Larry, when it involves coming in, have a blood test, go home, they like that, and they get a high utilization.
Yeah, thank you very much. All right, so at this point, what I'm going to do is I'm going to go around again the roundtable, call out your name, and if you have something to share or a question or a comment, please feel free to do so. And again, I'll just call out in the order that they show up on my screen. So Ed Schwartz, Ed, comments or questions?
Yeah, no, just a couple comments. I think we're in a really weird phase right now when it comes to cancer screening. There's a lot of tests, like these multiple cancer early detection blood tests that are being pushed on the market. But quite frankly, their studies are not great studies. They're not population-based. When you look at their sensitivities and specificities, they were based on studies that were done when you have, for example, 1,000 people you know have cancer and 1,000 people you don't have cancer. So the sensitivities and specificities are falsely elevated. And so the population-based study that started to occur, was in UK. It was supposed to be 1.5 million members. At 140,000, UK stopped the testing because it did not show the results that were promised, which was detection of earlier cancers. And this seems to be a consistent theme we're seeing, and we seem to see more and more heavy marketing on these tests that really aren't FDA approved and don't have any support of most societies, clinical societies. And even the one that is FDA approved, the SHIELD test, does a wonderful job at testing for stage 2 to stage 4 cancers, but does an absolutely horrible job of finding precancers and stage 1. And so easy, to Michael, you said it perfectly. I mean, easy is okay, but not if it's not effective and doesn't give you the results you need. So I think we're at a stage where we've got to, number one, make sure that people are aware of the realities of the test. Number two, many of these tests, they even say, this doesn't take place of any of your current testing. So they add expense. And when their false positive rates add even more expense as you try and chase something that you may not find. So I'm excited that there's new technologies being evaluated, very hopeful that they will improve with more rigor, and I think they will. And I think the future is bright, but we've got to make sure that we follow the science. So I hope that helps.
Thanks very much for those observations, Ed. Tony Musi, Tony, comments, questions?
Hi, Larry, thanks. Thank you for the presentations. And it was good to hear from Dr. Webb. I learned about his product in St. Louis, and it was great to hear that overview again. I appreciate that. For Robert, I'm curious, as a primary care physician, how is my experience working with an oncology partner going to differ if they're an NCTA member?
I think the only difference will be we just have the ability to contract directly. And I think some of the independent practices that we have, we can do it on a national, local, or regional level. But again, we're supporting community oncology practices by just connecting them with referral sources such as an on-site clinic or being able to provide those services. So I think you'll still find the same relationship better. The same, because we're all part of supporting independent community oncology practice. So there are a lot of our practices that work directly with primary care providers and have a very close referral relationship. But offering some of the ability to just work together, I think, in a independent community oncology setting where it's affordable, accessible, and high quality. So again, the practices that are with us are really are independent, local, affordable, and accessible. So I think you'll still find the same high quality and affordability and accessibility that you would through one of the NCTA practices.
Okay. Is it Tony? All right. Thank you. Manny Berenchi, Manny, comments or questions?
This is a great presentation. Thank you so much. I just wanted to put a plug in for some of the work I've been a part of. I did put it in the chat. So we're actually trying to help train occupational medicine clinicians to leverage some of the tools that we currently have within our respective EHRs to actually create what we call an occupational medicine consult that our oncology colleagues can leverage to help with return to work planning. I just wanted to let folks know that you can access the training through that website. And I'm trying to kind of spread the word about this because I know this world very well. I've taken care of a number of workers who, have developed cancer, and trying to work with them to ensure that they can continue to function is something that we can really contribute to. So happy to continue the conversation. Thank you.
Hey, Manny, why don't you send me a note after this, and perhaps we can use NOWIC as a vehicle to make that training available.
Will do.
Great.
Thank you.
Thank you. Lauren Mendek, Laura, comments or questions? Laura Mendek?
Yep, trying to find all my buttons here. I appreciate this a lot as a primary care physician as well. I reiterate a lot of what Dr. Schwartz said in terms of we just need to make sure we're thoughtful on what we're using, especially with some of the blood tests. Yeah, they're convenient, but we don't want to create duplicate costs because the data isn't quite there as screening tests the way some of the other ones are, even if they don't get turned or mailed back in. So, but thanks, this is great.
Thank you very much. Lauren Emery, Lauren?
I don't really have a whole lot of questions. I do appreciate you guys sharing this information. We're at Larimer County, we're a self-funded medical plan, so kind of echoing what other people have said, just making sure that we're ordering tests and making sure that we're not duplicating the costs. So again, I appreciate you guys sharing this information. It was very beneficial.
Thank you. McKenna DeSouza, McKenna?
Thank you for the presentation. No questions at this time, but looking forward to using some of the insights that were provided.
Okay, thank you. Tim Newman, Tim, any comments, questions?
Yeah, these are two excellent presentations, and I really appreciate you bringing to the forefront, Rob, the role of NCTA and Michael, your product. I've been involved in medical case management of comprehensive care and return to work for a large utility for many years. And obviously the prevalent chronic illness is cancer, treatment of cancer and people returning to work. So the challenge is that the good part is they're getting better and the challenge is getting them back to work. So I wholeheartedly endorse this as a part of on-site care. We also use care management and return to work techniques in our medical case management for a self-insurer. So your coordination of community oncologists and that part of it, Robert, is really excellent. And then Michael, your highlights of these screening tests are very important. Although I recognize what Ed said, maybe some limitations, but it's nice to see the whole picture come together. And my thanks to NAWOC for presenting this to us all.
Thank you, Tim. Just a sidebar note, one of the other areas of coordination that often is overlooked is coordination of benefits. Someone who's got cancer often doesn't know what benefits they're covered, whether they still have a job, if they can work part-time. So the HR person has to be part of that discussion with the clinical team at the center or whomever is helping the patient so they can guide them through the array of benefit programs, coverages, et cetera, long-term disability, whatever the case might be. It's really important. Betsy Nola Kirby. Betsy, comments or questions?
I appreciate the comments about the blood testing and the over-testing potential and the sensitivity. I do have a question about levels of care that the clinic could provide. Some of my clients have built their clinics and kept these rooms on standby for infusion. So Dr. Webb, wondering how what your stance, or anybody else, Dr. Schwartz, any of the physicians, what are your thoughts about, some level of care being provided in the clinics to allow people to have less time away from work if possible?
I'll start first, Robert, if you have any follow. I think having treatment inside a clinic is a great idea to help, and people, employees and patients will value that as a way. So I support treatments in workplace clinics. Again, obviously, and with the caveat that it's all appropriately performed by the correct personnel and in compliance with all standards. But having that element there in close proximity to keep someone productive, it reinforces both the active role of the employee has in his health and combines that too with the morale boosting effects of the corporation itself. So I'm a big fan of it.
Yeah, I think just to add on to that, just like I had mentioned, setting up an oncology clinic to do oncology treatments can be very expensive. You have to have, a clean room, a ventilation system, where you can mix these drugs because they are, toxic. And when you're mixing them, you have to follow a lot of safety procedures. But there are a lot of options and a lot of things that an on-site work clinic can provide in terms of treatments. These can be infusions for dehydration, anti-nausea medication, really some of the vitals. So there are appropriate treatments that can support an oncology patient that are, very effective in an on-site health clinic. But we just need to make sure that, like, was mentioned by, Michael, that these are compliant with, local and federal regulations, and then also safe to give, and also that you're keeping not only your patients safe or your employees safe, but also the people who treat them, because you've got to make sure that you've got all the appropriate things in place.
Just one thing to add to what both have said real quickly is that so we do have a couple sites where we run infusion centers. They're very large sites, and the reason that we have only accomplished that in very large sites is the complexity and the risk. And whenever you infuse a medication, number one, your risk can go up for side effects, and you have to know and have people there that have expertise not only in mixing the drugs, but also in case there's any complications, being able to respond to them effectively. But where I think on-site really can be valuable, and where we can close a loop that seems, I've been doing this for 30 years, and it seems as we have continued to fragment care more and more, or do a handoff, but then turn and walk away, patients and their families don't get the level of care and support they need. And I would say it is extremely important to take advantage of the on-sites, because they can be that educator that integrator, and can really support the family, the patient, in a way that fortunately we've lost at times in primary care. There's still some great primary care offices out there do a wonderful job, but it has become more challenging. And so again, I think it's that integration, tying everything together that becomes so vital. Also, having easy access to care to identify those early reactions, because it's much easier to treat an early reaction. If they become late, sometimes again, people end up in the hospital and they're exposed to everybody else who's sick there when that may not have needed to occur.
Thanks very much, Ed. Appreciate that. Carrie Cameron, Carrie, comments or questions? Carrie Cameron? Yeah.
Trying to get off mute there. Apologies. Yeah, I am not a clinician. I appreciate all the experience and viewpoints. I was in particular very interested in some of the navigation opportunities coming from the direct to employer primary care and occupational health space. I know there's a lot that we're trying to do to assist with that process, just to augment things like massage and behavioral health and some of the other things that are in direct treatment of cancer that can really help someone on their cancer care journey. So just really appreciate everybody's perspective and look forward to continuing to focus on this.
Thank you, Carrie. Deanna Hahn, Deanna, comments and questions?
No, I don't. Thank you for the presentation. It was very interesting.
Frank Cohen, Frank, any comments or questions?
Thank you, Larry. To the panel and to the audience, I would say clinics are founded on trust. And as you reflect on the prior year and the year ahead of us, how can you enhance that trust relationship with your patients, with your employers, self-funded health plans, prospects, patients under care, is to empower clinics to become that hub of knowledge. As patients seek care for cancer, what are the clinical pathways you want to present to your patient populations? And how can you optimize the services you provide to get to definitive treatment sooner? I'll borrow Dr. Webb's word, definitive treatment sooner, and versus whether that be through Rob's network or whether that be at the on-site center for some portion of the care. These people trust you, and they trust that you're providing that nav or the actual treatment to get to the right place. That's super valuable. That's like gold. So Larry, thank you for your work too, to bring us together today. We appreciate it. And that's all I had. Thanks.
Thanks, Frank. Jim Meacham, Jim, comments, questions?
Yeah, thanks for the presentation. It was really great. It's very, Dr. Webb, it's kind of, we're clipping some slides because it really resonates with a lot of the conversations we're having with our employers. We do derm days where we see anywhere between 20 and 25 people for a skin check. A dermatologist comes in and checks them, and they're very successful from a patient point of view. We really just charge cost. But we're, I guess that at some point when you're doing that for an employer that has maybe 1,000 employees, you do start to lead into conversations. This is great. I want more of it. And we can't necessarily do it every day, right? We run into a dermatologist problem of there's a resource issue, right? Of a supply demand. And then there's probably a money issue at some point for certain of these employers that we're charging a certain amount for that type of day for only 23 people, but you catch one cancer and that solves that problem over many of them, which we do. My question is based around the fact of, if we want to scale this in some meaningful way to our employers to say, okay, it's successful. We love this. Maybe let's say they're doing it 4 times a year. So we're maybe seeing 100 people. Sometimes there's some frequent flyers in there that like to come to the second term day as well. So we didn't even see 100. So my question is, where should we turn our attention? Where can we get the lowest hanging fruit right now for the types of screens that we could augment or complement what we're currently doing to scale maybe that number in a meaningful way and still provide some sort of ROI to these employers and with getting to see a lot more patients, or at least getting the chance to screen a lot more of them through maybe some ways that aren't hands-on?
Yeah, I'd love to answer that question, and I'll be brief because it's part of my mission in bringing this um, skin cancers to definitive treatment sooner. And the lowest hanging fruit it really relates to the fact that 2/3 of skin cancers are discovered at home by someone other than the patients themselves. And it's usually the primary stakeholder who has found it. And what I have found in my experience, being in this community, as being in both the big end of the funnel and the narrow end, where we see these avoidable advanced cancers, if you can empower that primary stakeholder at the point of discovery, and then there's a slide that I showed where a spouse is looking at her husband, and she's pointing out, "Hey, I'm worried about that spot. It's new." And what I see that correlates in that slide is at that point of discovery, there's a decision being made to wait until it becomes symptomatic and past. That's the lowest hanging fruit. If you can empower an action pathway there, because where I see what happens is these patients will wait and then they forget about it. And on average, 16 months happens before it resurfaces, and you're looking at a stage and a half downstream. If I was running a large scale business, I would empower those people at home to have a way to identify a spot and then get into that work site clinic and go down the next pathway. And we've had very good results in that, in both avoiding catastrophic claims by keeping melanomas in stage 0 and 1, as well as non-melanoma skin cancers that would have involved a 2 or a 3 or a 6 week process for a healing flap or graft, because we caught it when it was the size of a pea rather than the size of a marble or a ping pong ball.
Great. Thank you. Nick Famos, Nick, comments or questions?
No, great presentation. Thank you. Jim kind of asked my question, actually. I did have a question for you, Dr. Webb, regarding sorry. Would you say that the gold standard for screening is it these fancy gadgets, or is it really trying to connect these specialties to the on-site clinics in the best way that we can and driving the utilization through the clinic?
Well, I'm gonna go back. It's the point of it's empowerment at the point of discovery to provide a pathway, and getting them in somewhere soon. If they know that they can get a quick response and a convenient, easy response, they're going to use that as a pathway, and then care can accelerate. It's interesting, in skin cancer, 4 out of 5 spots are benign that people become concerned about, and then 1 out of 5 require some treatment. But and so I really think that the key point of this is, as you get them into that pathway, you have to first start to avoid that appraisal delay when they're saying, "I'll just watch and wait because I'm not sure if this is anything significant and if it's worth scheduling appointment to be time away and the cost for work." So having an opportunity to give them some guidance and empowering that primary stakeholder, who's that person who discovered it at home, and it's usually somebody other than the patients themselves.
Okay, so your focus then probably would be education. Education
Is
to
part of it, but you have to have an action pathway. Without an action pathway, interestingly, that 2/3 of the people, despite nearly millions, almost $1 billion spent on public awareness campaigns, even highly educated people still don't know 2/3 of the time the difference between an early skin cancer or a benign spot. So education's only part of it. You have to empower an answer. And whether it's someone can get an appointment at a worksite clinic to have an opinion to help guide them further down the care pathway, or rather say, no, that spot's okay. That's the critical element I have found in my 30 years of treating avoidable advanced skin cancer.
how easy is it to get in? I have a question, or I'd like to contact my provider.
Okay, so you're bringing up a great point. Dermatology access in specific can be difficult. But as a practicing dermatologist, and how we solve this problem is my colleagues are eager to see spots that have been identified by each other. We know an early spot when we see it. So they will get a spot or reserve a spot within a week to have that evaluated. And that's the key. It's a high acuity, high value patient where specialty colleagues like dermatologists will hold a spot open for that vetted patient to come in to get to definitive treatment sooner. And they do that knowing that it's been vetted and that this is not a issue from the worried well coming in for a spot that is okay. And that does happen in overutilization. And that's what we're looking to avoid is getting the right patients in at the right time.
Great. I'm sorry, we're at the end of the hour. Thank you all very much. Thank you, Robert and Michael, for excellent presentations. And this will be recorded and sent to everyone, including my dog.
Thank you, Larry. Thank you, everybody.
Bye.
Have a great
Thank you.
week.
Thanks, everybody.
Bye.